Kanski lecture series, and this is the retinal vascular diseases part 10, and in this part we are going to discuss about the primary retinal telangiectasia. So retinal capillary telangiectasia is relatively common. Most cases develop secondary to another retinal condition. So basically telangiectasias are the dilated capillaries, vessels, and these are relatively common, and it can develop secondary to other conditions as well, typically involving inflammation or vascular compromise. For example, diabetic retinopathy or retinal vascular occlusion. Um, Primary retinal telangiectasia comprises of a group of a rare idiopathic congenital or acquired retinal vascular anomalies characterized by the dilatation and tortuosity of the retinal blood vessels, multiple aneurysms, vascular leakage, and the deposition of the hard exudate. So whenever there is a presence of a telangiectatic vessel, there can always be some leak. You can always expect some leakage, and whenever there is a leakage, you can expect some kind of a hard exudate deposition. So basically, the primary retinal telangiectasias are usually idiopathic, congenital, or it can be acquired. And basically, these are dilatation and tortuosity of the retinal blood vessels. Retinal telangiectasias involve the capillary bed, although the arterioles and venules may also be involved. So let's see figure 13.56. So you can see a primary retinal telangiectasias. What you can see here are the hard exudates. You can see some leakage, edema, circinate exudates, a B showing a corresponding FA showing hyperfluorescence in the multiple area. So then there are an idiopathic macular telangiectasia, which are discussed in chapter 14. Then there is a Coats disease. So Coats disease is basically the presence of a telangiectatic vessels. It is basically a unilateral disease present in the boys in usually when the almost when the 10 years of age. So let's get started. Coats disease is an idiopathic retinal telangiectasia that generally occurs in early childhood. It is associated with intraretinal and subretinal exudation and frequently exudative retinal detachment without the signs of the vitreoretinal traction. So it is one which is basically formation of the telangiectasias leading to exudation formation in the intraretinal and subretinal area, and then leading to the exudative retinal detachment. About 75% of the patients are male, and 91% have involvement of only one eye. So most of the patients are male, and only one eye is being involved. It is unilateral. Presentation is most frequently in the first decade of life. Although it is not obviously inherited, a genetic predisposition may be involved. At least some patients have a somatic mutation in the NDP gene, which is also muted in the Nori disease. So basically, it is non-hereditary disease and so sporadic disease, and sometimes there is a mutation in the NDP gene, which is also present in the Nori disease. It is now considered that a Leber-Millery aneurysm, previously regarded as a distinct condition, represent a generally milder form of the same disease presenting later in a more localized pattern and carrying a better visual prognosis. So basically, it has been thought that a Leber-Millery aneurysm is the same as like a cord disease, but it is milder and present later in the age. Differential diagnosis from the other causes of the leukocoria in childhood, particularly retinoblastoma, is important. So, differential diagnosis of retinoblastoma is very important. Other retinal conditions that may mimic cord disease are familial exudative vitreoretinopathy, FEVR, retinal hemangiomas in von Hippel-Lindau syndrome, and ROP. The prognosis is variable and is dependent on the severity of involvement and presentation. Younger children frequently have a more aggressive clinical course. Next is a diagnosis. How do you diagnose a case of a cord disease? So symptoms are unilateral visual loss. There will be strabismus and leukocoria. Fundus will show the telangiectasias and fusiform focal aneurysm or arteriolar dilatation. So there will be the arteriolar dilation often initially in the inferior and temporal quadrant between the equator and the ora serrata. So between the equator and ora serrata, there will be the exudation formation. Intra and subretinal exudates often affecting areas remote from the vascular abnormalities, particularly the macula. Progression to extensive exudative retinal detachment may occur. Complication may include rubus, iritis, glaucoma, uveitis, cataract, and phthisis bulbi. So complication will be like NBIs, it can be glaucoma, it can be uveitis, it can be cataract and phthisis bulbi. Fluorescent angiography in mild cases show early hyperfluorescence of the telangiectasias and aneurysmal dilatation and late staining and leakage. So it will show us early hyperfluorescence and late staining. OCT may be useful for the assessment of the macula in cooperative older children. So this is a Coats disease. A is showing leukocoria, B is showing retinal telangiectasias and aneurysmal arteriolar changes, C is showing intraretinal exudate formation, D is showing progressive involvement, FA is showing FA venous phase showing hyperfluorescence. So this is our hyperfluorescence, and this is a late phase which is showing the leakage of the telangiectatic vessel. So what do you treat? Treatment observation in a patient with mild non-vision threatening disease and those with comfortable eye with the total retinal detachment for whom there is no potential for restoration of a useful vision. So whenever there is a total retinal detachment and there is no prognosis for a useful vision, then observation can be appropriate, and it can also be observed in a mild non-vision threatening disease. Laser ablation of a point of leakage should be considered if progressive exudation is documented. So if the exudation is progressive, then you can ablate the area of the leakage. Multiple repeated treatment over an extended term are commonly required. You can also use anti-VEGF therapy. Limited studies of the anti-VEGF therapy have been carried out, but initial results are promising, including as an adjunct to laser. Long-term safety in childhood remain undetermined. Intravitreal triamcinolone 2 to 4 milligram has been used with the good effect in eyes with total exudative retinal detachment. So you can also use anti-VEGF, you can also use intravitreal triamcinolone. Cryotherapy has a very important role. Cryotherapy with a double freeze thaw method in eyes with extensive exudation or a subtotal retinal detachment, although this may result in a marked reaction with increased leakage. So especially it is used when there is a very extensive detachment and there is a subtotal retinal detachment. Therefore, laser photocoagulation is still the preferred option if possible. So this is exudates in a relatively mild Coats disease. B is showing resolution several months after the laser photocoagulation. Next is vitreoretinal surgery can be considered in eyes with the significant tractional pre-retinal fibrosis and total exudative retinal detachment. There is a poor visual prognosis, but successful retinal reattachment may prevent the development of a neovascular glaucoma. So usually the visual prognosis after the retinal surgery is not good, but it can prevent the formation of the neovascular glaucoma. Enucleation may be required in a painful eyes with neovascular glaucoma. Next is an Eales disease. So Eales disease is basically the disease which is idiopathic, and there is an occlusive disease which is basically associated with the branch vein occlusion, and it has some features like a diabetic retinopathy. So introduction, Eales disease is an idiopathic occlusive peripheral periphlebitis. So there will be peripheral periphlebitis. It is rare in white, but it is an important cause of a visual morbidity in young males from the Indian subcontinent. It is characterized with the three overlapping stages: inflammatory stage, occlusive stage, and retinal neovascular, and is diagnosed principally by the clinical examination. So it has three stages: inflammation, occlusion, and third is the retinal neovascular formation. The visual prognosis is good in majority of the cases. Tubercular protein hypersensitivity may be important in the etiology, but evidence is conflicting. Some patient may have a tubercular vasculitis. Diagnosis: floaters or sudden visual reduction due to vitreous hemorrhage. So there will be the symptoms will be like there will be the sudden decrease in vision due to hemorrhage. There can be systemic neurological features have been reported. Mild anterior uveitis is also present. The condition is typically bilateral. So this is a bilateral disease, although often asymmetrical. So first there is an inflammation which is a peripheral periphlebitis, which include that there will be the sheathing of the vessel, there will be the superficial retinal hemorrhages, sometimes cotton wool spots, there can be pigmented chorioretinal scars may be seen. So whenever there is an occlusion phase, there will be the branch retinal vein occlusion. Peripheral capillary non-perfusion with microaneurysm, tortuosity, vascular shunt, and neovascularization. So whenever there is a non-perfusion areas, It can lead to microaneurysm formation, shunting formation, and new vessels as well. And when there is new vascularization, it can lead to recurrent vitreous hemorrhage. One third of the eyes may develop at the junction of the perfused and a non-perfused retina. Disc new vessels can sometimes develop. The vitreous hemorrhage tends to be limited and to absorb over weeks, but can persist in some cases. Macular involvement with the same changes can occur but is rare. Complications include tractional retinal detachment, macular epiretinal membrane, neovascular glaucoma, and cataract. So, glaucoma and cataract can be, new vessels are occurring and it can cause the neovascular glaucoma. There can be cataract formation. Tractional retinal detachment can occur and macular epiretinal membrane. FA will identify vasculitis and areas of non-perfusion. Wide field imaging is especially helpful. Investigation should be performed to rule out other causes of vasculitis, sarcoidosis, tuberculosis, and peripheral retinal neovascularization, hemoglobinopathies. So, investigations is performed to rule out vasculitis like sarcoidosis, tuberculosis, and other hemoglobinopathies. So, what are the treatments? So, in a case of inflammatory phase, we give steroids. So steroid, periodical, systemic, topical, and intravitreal steroids seem to be helpful in the inflammatory stage. So you can give steroid periodically, you can give systemic steroids, you can give topical steroids, you can even give intravitreal steroid. Antituberculin treatment can be given for those who are tuberculin positive. This is strongly advocated by some authorities, but it is controversial. It may be considered in selective patients in combination with steroid, either to avoid reactivation of a prior tubercular infection, for example, strong positive skin test, quantiferon, or possibly when the severe ocular inflammatory signs are present. Scatter photocoagulation or cryotherapy of a non-perfused retina to reduce the neovascular stimulus. So if there is a non-perfused retina, we can give this photocoagulation as well. Intravitreal and VEGF inhibitor may be helpful, but research is ongoing. Vitrectomy for persistent vitreous hemorrhage, tractional retinal detachment, and macular epiretinal membrane. So vitrectomy is done for the PVH, we can do for the tractional detachment, we can do for the macular epiretinal membrane. Radiation retinopathy may develop following the treatment of the intraocular tumor by the plaque therapy, brachytherapy, or external beam irradiation of the sinus, orbital, or nasopharyngeal malignancy. So let's see the figure of first see the figure of the Eales disease. So this is an Eales disease. A is showing a peripheral vascular sheathing. So this is a sheathing of the peripheral vessels, and B is showing peripheral neovascularization. So this is a new vessels being present, and this is a recurrent hemorrhage from the new vessels. So basically, radiation retinopathy occurs whenever you are giving the radiation just around the eyes, or you can if like you're treating the sinus from the radiotherapy, you're treating brain. So radiation retinopathy can occur. So radiation retinopathy may develop from the treatment of the intraocular tumors by plaque therapy, brachytherapy, or external beam irradiation of the sinus, orbital, or nasopharyngeal malignancy. It is characterized by the delayed retinal microvascular changes with endothelial cell loss, capillary occlusion, and microaneurysm formation. So first there will be the microvascular changes which will result in endothelial cell loss. There can be capillary occlusion and microaneurysm formation. Affected patient may also develop cataract and keratopathy. There is some evidence that it is more likely to occur in genetically predisposed individuals. The interval between exposure and disease is variable and unpredictable, although commonly between 6 months and 3 years. There is a direct relationship with the radiation dose. Signs: capillary occlusion with the development of telangiectasias and microaneurysms, retinal edema, exudates, cotton wool spots, and hemorrhage. So first, there can be in a radiation retinopathy, there can be capillary occlusion, which can lead to the development of telangiectasias and aneurysms. After that, of telangiectasias, you know that there is an exudate formation, and exudate, retinal edema, exudate, and cotton wool spot and hemorrhage can occur. The changes are best seen on fluorescein angiography. Proliferative retinopathy can occur. There can be papillopathy. Radiation optic neuropathy may occur, but it is less common as the nerve seems to be less sensitive than retinal vessels. Treatment is frequently unsatisfactory. Option include laser, steroids, and intravitreal anti-VEGF. So depending on which stage our retina has, you can treat it with laser, if there is a non-perfused area, or you can treat with intravitreal anti-VEGF if there is a proliferative retinopathy, or even steroid as well. Prognosis depend on the severity of the involvement. Poor prognostic features include papillopathy and proliferative retinopathy, which may result in vitreous hemorrhage and tractional retinal detachment. So this is a radiation retinopathy, which is showing us an A, microvascular abnormalities, cotton wool spots, and hemorrhages. So there is a cotton wool spots, hemorrhages. B is showing severe macular involvement. C is showing aneurysmal telangiectasias. FA of the aneurysmal and telangiectasias lesion associated with retinal capillary non-perfusion and microvascular abnormality. E is showing disc new vessels, so this is showing the new vessels at the disc, and arteriolar occlusion and microvascular abnormalities and hemorrhage. F is showing us a papillopathy and cotton wool spot following a treatment of the choroidal melanoma. So this is a choroidal melanoma. After it gets treated, it can lead to like a cotton wool spot and papillopathy. So it is showing us a disc new vessel, so there is a occlusion and there can be microvascular abnormalities as well. So next is the Putsch retinopathy. So Putsch retinopathy is basically when there is a severe trauma and it can lead to the eye changes. This is known as Putsch retinopathy. Putsch retinopathy may follow a severe trauma, especially chest compression, long bone or head injury, and involve occlusion and ischemia associated with microvascular damage. It is thought to result from embolus and in some cases vascular occlusion by other mechanisms such as complement mediated white blood cell aggregation. So there is two possibilities. First is basically due to embolus, and secondly is white blood cells are getting accumulated. When it results from the cause other than trauma, for example, fat or amniotic fluid embolism, acute pancreatitis, preeclampsia, and systemic vasculitis, it is sometimes referred to as the Putsch-like retinopathy. So it can be occur due to other causes like preeclampsia, amniotic fluid embolism, acute pancreatitis, systemic vasculitis. Presentation is with the sudden bilateral visual reduction, typically to 6 by 60 or less. Multiple unilateral or bilateral superficial white retinal patches, capillary bed infarct known as a Putsch flecken resembling large cotton wool spots are seen, often associated with superficial peripapillary hemorrhages, typical cotton wool spots, and disc swelling. So basically it is resulting from the bilateral white retinal patches. There will be the capillary bed infarcts, which will be like Putsch fleckens, which resemble like a large cotton wool spots, and they can sometimes associated with peripapillary hemorrhages and disc swelling. Elevated complement 5A level may be diagnosed when there is no history of trauma. The acute fundus changes usually resolve within a few weeks, but only a small proportion will regain normal vision. Treatment of the underlying cause is not always possible. Next is a Valsalva retinopathy. Valsalva mean when you do Valsalva maneuver, and it can lead to the retinopathy. The Valsalva maneuver consists of a forcible exhalation against a closed glottis. So when the glottis is closed, you are doing exhalation, thereby creating a sudden increase in intrathoracic and intra-abdominal pressure. For example, weightlifting, blowing up the balloons. The associated sudden rise in venous pressure may rupture the perifoveal capillaries, leading to the premacular hemorrhage of the varying severity. So, if there is a sudden increase in venous pressure, it can lead to perifoveal capillary hemorrhage, which can lead to premacular hemorrhage. Vitreous hemorrhage may also occur. Treatment is with observation or ND-YAG laser membranotomy in some cases. So this is a Putsch retinopathy. A is showing as a small, B is showing a moderate, and C is showing large. And we can do the membrane hyalotomy to resolve this case. Lipemia retinalis is a rare condition characterized by the creamy white discoloration of the retinal vessels in some patients with hypertriglyceridemia. So whenever there is a high triglyceride in the blood, it can lead to the discoloration of the retinal blood vessels. It is known as a lipemia retinalis. In mild examples, only peripheral vessels are affected, but in extreme cases, the fundus takes a salmon color. The visualization of the high levels of chylomicron in the blood vessel account for the fundal appearance. Visual acuity is usually normal, but the electroretinogram amplitude may be decreased. So so basically, when the disease is quite mild, only the periphery is being affected, but when it is severe, the fundus appear as a salmon colored. And the appearance of this fundus is due to the high levels of the chylomicron, and visual acuity is normal, but the ERG amplitude is decreased. In a patient with a visual loss after severe body trauma, examine the posterior pole of both eyes for signs of butcher retinopathy. So this is a lipemia retinalis. So this is, you can see the whitish discoloration of the vessels. Retinopathy in blood disorders. So it can be due to leukemia. So leukemia can cause the retinopathies, same as anemia and hyperviscosity syndromes. So leukemia are malignancies of the hematopoietic stem cells involving the abnormal proliferation of the white blood cells. So basically, leukemia is a blood cancer or blood disorder malignancy in which there is an abnormal proliferation of the white blood cells. Acute leukemia is characterized by the replacement of the bone marrow with immature blast cell. So acute leukemia is where the bone marrow is being replaced by the blast cells. Chronic leukemia is associated, at least initially, with well differentiated mature leukocyte and occur almost exclusively in adults. The four major variants of the leukemia are acute lymphocytic, acute myeloid, chronic lymphocytic, chronic myelocytic. So the acute lymphocytic, in which the so basically there are two types of cells, lymphocytes and myelocytes. So whenever there is an increase in the lymphocytes, they are known as acute lymphocytic leukemia, and when there is a myeloid cells being increased, it is known as acute myeloid. So acute lymphocytic lymphoblastic predominantly affect the children in whom there is around 90% 5-year survival rate. Myeloblastic is most frequently seen in older adult. So basically, age is very important factor in differentiating such lesions. So acute lymphocytic occur in children and acute myelocytic occur in the older adults. Chronic lymphocytic has a very chronic course and many patients die from unrelated disease. Chronic myelocytic has a progressive clinical course and often has a less favorable prognosis. So, what are the ocular features of the leukemia? Ocular involvement is more commonly seen in acute than the chronic form, and virtually any ocular structures can be involved. So, ocular area can be involved. Usually, it is in the acute leukemia. Primary leukemic infiltration is fairly rare. Secondary changes, such as those associated with anemia, thrombocytopenia, hyperviscosity, and opportunistic infection, are more common and include intraocular bleeding, infection, and vascular occlusion. So secondary changes can also occur because of anemia associated with leukemia, thrombocytopenia, hyperviscosity, and all the opportunistic infection. It can lead to intraocular bleeding, infection, and vascular occlusion. So fundus shows retinal hemorrhages and cotton wool spots are common. Rod spots are the retinal hemorrhage with white centers. The whitish element is thought to be composed of a coagulated fibrin in most cases. They occur in acute leukemia and in a range of other conditions such as bacteremia, classically subacute bacterial endocarditis, diabetes, hypertension, and anemia. So basically, the rod spots are basically having a reddish lesion with the center of being associated with a whitish material. So the whitish material is composed of basically fibrin, and it most likely associated with leukemia. Other causes include anemia, diabetes, hypertension, and endocarditis. So you can see that there is a retinal hemorrhage in a case of leukemia is showing numerous multiple flame shaped hemorrhages with cotton wool spots. So these are cotton wool spot and flame shaped hemorrhages. This is showing us a premacular bleed, and C is showing us a large letrohyalide hemorrhage. A separate white side layer is evident. So, peripheral retinal neovascularization is an occlusion of occasional feature of chronic myeloid leukemia. So, in a CML, the peripheral neovascularization can occur. Retinal and choroidal infiltrate may occur, most commonly posterior to ocuator, and may masquerade as posterior uveitis. In chronic leukemia, they may give rise to the leopard skin appearance. Scattered hemorrhage may occur in patient with a thrombocytopenia. Optic nerve infiltration may cause swelling and visual loss. So, peripheral retinal neovascularization occur in a case of a chronic myeloid leukemia, and retinal and choroidal infiltrates can also occur, and they masquerade as a case of a posterior uveitis because after settling down, it gives us the appearance of the leopard skin appearance. Optic nerve can also be involved, which causes swelling and visual loss. Other features: orbital involvement, particularly in children, iris thickening, uh, iritis and pseudohypopion, spontaneous subconjunctival hemorrhage, and hypema, cranial nerve palsies. So this is showing us a rot spot. A is showing typical feature. The white center is presumed to be coagulated fibrin. B is showing rot spot with surrounding hemorrhage. So 13.767 is showing blood film in leukemias. A is showing bone marrow aspirate in acute myeloid leukemia, showing immature blast cells. B is showing peripheral blood smear in chronic lymphocytic leukemia, showing many mature lymphocytes. So next is this is a fundus changes in a case of a hematologic disorder. A is showing peripheral retinal neovascularization in a case of a chronic myeloid leukemia. B is showing us a leukemic chorioretinal deposit. So this is a deposit. C is showing leopard skin of appearance due to choroidal infiltration in chronic leukemia. D is showing scattered hemorrhage. So this is an acute leukemia, orbital involvement, and this is a pseudo hypopion formation. So anemia are a group of disorders characterized by decrease in the number of the circulating red blood cells or in the amount of hemoglobin in each cells, or both. So basically it can be due to the red blood cells are being decreased, or due to decreased hemoglobin, and it can occur due to both. Retinal changes in anemia are usually innocuous and rarely of a diagnostic importance. So there can be retinopathy, can occur optic neuropathy. So retinal venous toxicity is related to the severity of the anemia, but may occur in isolation. Dot blood and flame shaped hemorrhages, cotton wool spots, and rot spots are more common with coexisting thrombocytopenia. So the same can occur with the anemia. Optic neuropathy may occur in a case of a pernicious anemia, whenever there is a vitamin B12 deficiency anemia. So this is a hyperviscosity. The hyperviscosity states are the diverse group of rare disorders characterized by the increased blood viscosity due to polycythemia or abnormal plasma protein. So polycythemia is caused by the neoplastic proliferation of the erythrocytes. So erythrocytes are being proliferated with an increased bone marrow activity and hyperviscosity. Waldenstrom macroglobulinemia is a malignant lymphoproliferative disorder with monoclonal IgM production, with most frequently affecting the elderly men. Ocular features include retinal hemorrhages and venous changes, and occasionally RVO and conjunctival telangiectasias. So, retinal hemorrhage can occur, venous changes can occur, RVO can occur, and conjunctival telangiectasia can occur. So this is a retinal hemorrhage and gross venous dilatation and segmentation in hyperviscosity. So that's it for the part 10. See you in the next lecture.